A pleasant day, dear doctors and aspiring doctors. Welcome to our module in neurology, covering the basic neurosciences and its clinical correlates. This is Dr. Toom, and for this day, we are going to talk about the disorders of smell and taste. Now, this is my official reference, which is Adam and Victor's Principles of Neurology. This is under the section of disorders of special senses, and we will talk about today the disorders of smell and taste. So this is actually chapter 12. I'm going to summarize, I'm going to outline, and I'm going to emphasize on what are the key points and what are the must-knows from this chapter. Okay, so let's begin by talking about the sensations of smell and taste. Now, I want everyone to remember that these are special senses. Okay, we have here the taste, which we also call gustation. We have here the smell, which we also refer to as olfaction. So taste is gustation, okay? Smell is olfaction. Now, I like to remind students the first letter of olfaction is letter O. So O for odor. Odor is what we smell. Taste begins with the letter G. G for me sounds like gutom, which is of course Filipino for hungry, because this is associated with taste. So you might hear terms like gustatory and olfactory. They all refer to the sensations of taste and smell, respectively. Now, the sensations for both taste and smell. The N organs are actually chemoreceptors. Okay, they are not mechanoreceptors. They are not visual receptors, but they are chemoreceptors. These chemoreceptors would involve chemical substances as well as neurotransmitters. Now, I want to introduce you to this term called pheromones. Okay, this is derived from the term pherine and hormone, which means to carry or it is exciting. Now, humans as well as mammals and lower animals will produce pheromones. Pheromones are actually the odorants which are exuded from the body as well as perfumes. Okay, pheromones actually play an important part in sexual attraction. Okay, so I want you guys to remember that. Now, what are actually the causes why an individual will lose their sense of taste or their sense of smell? The first here would be an intracranial disorder. So this would be tumors. This can be something vascular, okay, like a stroke. This can also be infections, okay, which affect the intracranial structures. This can also be trauma. So tumors, vascular, infectious, and trauma. Now, neurodegenerative disorders can also cause the loss of taste and smell. One classic example here is Alzheimer's disease and Parkinson's disease. In fact, you should be able to learn in your neurology class that the early stages of Parkinson's disease actually begins in the olfactory nerves before you manifest with the classic tremors, the bradykinesia, and the rigidity. Now, systemic disorders from autoimmune diseases to infectious diseases, as well as systemic viral illnesses, can also cause the loss of taste and smell. Now, let's slowly highlight the anatomic and physiologic considerations with regards to the taste of smell. So we'll do the smell first. Now, everyone take a look at this figure here. So this is your brain. This is the brain. This is part of the temporal and the lower frontal lobe here. This is the nasal cavity. You have here the turbinates. Okay, you have the superior, middle, and inferior turbinates. Then you have here the ethmoid bone. I want everyone to memorize that. Okay, the ethmoid bone. Now, I hope you guys are familiar with the famous cribriform plate of the ethmoid bone. So here, you have some perforations in the cribriform plate. And here is the olfactory tract. I'm going to encircle it. And here's the olfactory bulb. And the terminal endings of the bulb are actually the olfactory nerve fibers. So these are the olfactory nerve fibers, which basically come in contact with the nasal mucosa. So you have nerve fibers, as you can see here, and their cells of origin are actually found in the mucous membranes of the upper as well as the posterior parts of the nasal cavity, particularly the superior turbinates as well as the nasal septum. Now, the entire olfactory mucosa covers about 2.5 square centimeters. Okay, so this area here. Now, always remember, okay, so the nose is here. Okay, let me reorient everyone. This is where the nasal cavity is. This is the nares. Okay, so let's try to orient ourselves with the topography of this picture. So this is the nares. Now, you have very sensitive blood vessels here, which are very prone to epistaxis. Can you type me, what do we call this plexus, which is found in the anterior nasal cavity? In fact, this plexus is the most common site of epistaxis. Okay, let's see your answers. Where is the most common site of epistaxis? Kindly type your answers in the chat box. Where's that most common site of epistaxis? Okay, very good. This is the Kisselbach's plexus. Okay, why am I mentioning this? Because nose picking is the most common cause of epistaxis. Epistaxis is a common condition which basically affects the nasal cavity and would also affect olfaction. Now, there are 3 cells which are found in the olfactory system. We have the olfactory or the receptor cells. We have the supporting cells, or what we call the sustentacular cells. And lastly, we have the basal cells. Now, I want everyone to memorize this. What are the 3 cell types of the olfactory system? We have the olfactory or receptor cells. We have the sustentacular or the supporting cells. Okay, then we have the basal cells. So I want everyone to remember that. Okay, olfactory and receptor cells, sustentacular or the supporting cells. Then we have the basal cells. Okay, now here is an illustration of basically the olfactory system. Now I want you guys to orient yourself. Okay, this is the cribriform plate. As you can see, there are perforations in the cribriform plate through which the olfactory sensory neurons will pass through. So we have here the olfactory bulb. And here are the cells. This is the basal cells, okay, which is basically directly under the cribriform plate. Then we have the olfactory receptor cells, which we also call the epithelial cells, okay? And what you don't see here, okay, is basically the clear cell, okay? This is the supporting cell, this entire green structure. This is the supporting or the sustentacular cell. Okay. Now, so we mentioned the olfactory or receptor cells, the sustentacular or supporting cells. So letter S for sustentacular, letter S for supporting. Now, what actually is the function of the sustentacular cells? They help maintain the electrolyte levels, okay, within the olfactory system. And this is particularly potassium, okay? So always remember, this maintains the electrolytes. Now, the basal cells are actually stem cells, okay, which means it gives rise to other cells. So the basal cells will actually be the source of both the olfactory as well as the sustentacular or supporting cells. So when the cells regenerate, new cells are going to be produced, okay? And they actually come from the basal cells, okay? Now, I'd like to remind everyone, this is going to come out in your exam, the classification of the neurons, particularly of the olfactory cells. They are bipolar. They are not multipolar, pseudopolar, or unipolar. They are bipolar, which means it has an axon and a dendrite. Okay? Now, I want everyone to remember that each of the olfactory cells, so here's a diagram, okay? It's a very busy diagram from your book, okay? But I just want to highlight this. Okay, look at what I'm encircling. This is the olfactory bipolar cell, okay? So please take note of that. Now, there are peripheral processes which are found on the olfactory cells, and these peripheral processes are what we call the olfactory rods, okay? The significance of the olfactory rods is this is where the cilia, as well as the hair cells will project from. So very important, okay, is the function of these hair cells. So these hair cells, as well as hair-like processes, okay, are the sites of the olfactory receptors. So anatomically, any damage, okay, any damage to these olfactory receptors or the bipolar neurons would cause absence of smell or perverted smell, okay? So we have central processes. So I want everyone to remember peripheral processes. These are the olfactory rods. Central processes. These are the olfactory phyla. Okay, so please take note of that. Now, what actually are these olfactory phyla? They are unmyelinated fibers, which are basically going to form fascicles, okay? We have fascicles, we have groups of nerve fibers, and these are the fibers that will pass through the openings of the cribriform plate. Now, I want everyone to remember, if there is a fracture of the cribriform plate, there is a big chance that you will lose the sense of smell, whether it's going to be temporary or whether it's going to be permanent, depending on the severity and the degree of the trauma, okay? So please take note of this. So any trauma, okay, affecting the cribriform plate or any tumor which compresses, okay, any tumor which compresses the cribriform plate. So I want you guys to remember that, okay? So here, let me enlarge that illustration earlier. So here are the bipolar olfactory cells. As you can see, look at this, okay? It has processes, two processes. So it has an axon and a dendrite. It has an axon and a dendrite. So as you can see, we have here all of these neuronal correct connections, and basically all of these signals and impulses will be transmitted to the primary olfactory cortex. So I want you to see all of these immediate connections, okay? Now, I want you guys to remember, okay, that if you collectively group all of the central processes. Now, what do we call the central processes again? Are the central processes rods or phyla? What are the central processes? Are they rods or are they phyla? Okay, great. They are called phyla or phyla. Once you collectively group the phyla together, then they would actually constitute the first cranial nerve or the olfactory nerve. Now, always remember, cranial nerve number 1 is the first cranial nerve to develop in utero, okay? It's the first cranial nerve to develop. And I want everyone to remember that all sensation is actually relayed to the thalamus except olfaction. So I want everyone to remember that. That usually comes out in exams. What is the only sensory modality which is not transmitted or relayed to the thalamus? And that is sensation, the sensation of smell. Okay, so olfaction. Now, I also want you to remember that the area of the olfactory system is also the only site in the body where neurons are in direct contact with the external environment. Okay, so please remember that. Now here, this is a downloaded pic showing you the Bowman's glands. Okay, so this is showing you the epithelial surface. Okay, so this is the olfactory epithelium. Now, the olfactory epithelium is basically covered with mucus. I think you guys can understand that. And the mucus is actually secreted by the Bowman's glands. Okay, let me repeat. The mucus is secreted by the Bowman's glands. Now, also found in the olfactory epithelium are your immunoglobulins, particularly immunoglobulin A and immunoglobulin M. Question: what is the most abundant immunoglobulin in the olfactory epithelium? So this immunoglobulin has secretory function. Okay, what is this immunoglobulin? Is it I or is it A? Okay, very good. IgA or immunoglobulin A has secretory function, and it's usually found in the mucosal surfaces, particularly the respiratory tract, the gastrointestinal tract. Now, we also have the protein lactoferrin, which is also found in the olfactory epithelium. We have lysoenzymes, and we have odorant binding proteins. Okay, so the olfactory epithelium is not just a set of nasal hairs. It is a complex area where you have specialized neurons, you have a mucus-producing Bowman's gland, you have immunoglobulins, you have lactoferrin, you have enzymes, and you have odorant binding proteins. Okay, now I want everyone to memorize this. This will come out in your exam. So first, this is the lateral view of the brain, the auditory cortex. This is what we call Hessel's gyrus. I like to remind students that letter H, Hessel's, is for H, hearing, because that's the auditory cortex. Then here, in this area here, which is actually Brodmann's 34, this is the olfactory cortex, which is responsible for smell. So where is the primary olfactory cortex? The primary olfactory cortex is actually found in the parahippocampal gyrus as well as the uncus. Okay, so it's basically part of the temporal lobe. So there is a misnomer that smell is in the frontal lobe. The primary olfactory cortex is found in the parahippocampal gyrus and the uncus. Okay, that is the uncus of the temporal lobe. So I hope everyone got this. So please remember this, that the primary olfactory cortex is found in the parahippocampal gyrus and the uncus. Okay, now question. What is the only sense that is not relayed to the thalamus? So we mentioned earlier that the thalamus is the major sensory relay center of the brain. All senses are relayed there except for the sense of smell or olfaction. Now, I want you to remember that olfactory impulses will reach the cerebral cortex, particularly the primary olfactory cortex, without relay through the thalamus. Now, let's dig into the clinical manifestations of olfactory lesions. Now, the book tells us that the clinical manifestations of olfactory lesions can actually be divided into four. Okay, and what are these four groups? We have quantitative abnormalities, qualitative abnormalities, olfactory hallucinations, and olfactory delusions. Okay, so please take note of this. What are the four groups? We have quantitative, qualitative, olfactory hallucinations and delusions, and higher order loss of olfactory discrimination, which we call olfactory agnosia. I want everyone to memorize this. So if you're taking down notes in your seats, I strongly encourage you to jot this down. Okay? Again, I strongly encourage you to jot this down. This is olfactory agnosia. So please take note of this. Now, let's begin with the first group. So under the disturbances of olfaction. So we have the quantitative abnormalities. Now, the quantitative abnormalities can be divided into two. We have the conditions which result to either the loss or reduction of the sense of smell, or those associated with increased olfactory acuity. So it's either loss or reduction or increased. So under the loss or reduction, we have two terminologies here. We have anosmia. A means absence. Then we have hyposmia, so decrease or reduction in the sense of smell. Then we have increased olfactory acuity. So we have hyperosmia. Okay, sobrang sensitive. So please take note of this. Now, under the qualitative abnormalities, we have the disturbances which lead to distortions or illusions of smell. Okay, we have parosmia, then we have dysosmia. Okay, parosmia or perverted sense of smell, then we have dysosmia. Now, I would like to share this with you, okay, that under quantitative, It's either hyposmia, anosmia, okay? And of course, we have what is mentioned in Adams, the hyperosmia, okay, the increased acuity. Then under the qualitative, which we actually call or group as dysosmia, it's either parosmia or troposmia, which means distorted or perverted olfactory sensation. Then there's phantosmia, which means you have a distorted sense of smell in the absence of an odor, okay, like a phantom smell, okay? Now here, under the disturbances of olfaction, we have what we call olfactory delusions or olfactory hallucinations. Now, I want everyone to memorize this. Olfactory hallucinations or olfactory delusions are usually caused by temporal lobe disorders or psychiatric disease. For example, schizophrenia. Okay. Now, why do temporal lobe disorders or lesions cause disturbances of olfaction? Why? Let's hear your thoughts. Why are there disturbances of olfaction? The reason is the temporal lobe is where the primary olfactory cortex is. Okay. So from olfactory hallucinations and delusions, we now have higher order loss of your olfactory discrimination. And this is known as olfactory agnosia. Okay. This is known as olfactory agnosia. So please take note of this. Okay. Now, this will come out in your exam. What is the most frequent clinical abnormality associated with olfaction? It is anosmia. Now, at times when the anosmia is unilateral, that means only affects one nose, sometimes even the patient can't recognize it. Now, always remember, unilateral anosmia can be demonstrated, okay, in the hysterical patient on the side of anesthesia, blindness, or deafness. So there are several conditions, and majority of those we will be discussing are actually under anosmia. So let's begin by differentiating unilateral and bilateral. So when there is bilateral anosmia, they always remember this is usually accompanied with the loss of the sense of taste. And this is what we call in neurology as ageusia. Okay. This is called ageusia. You've probably been taught that what you smell is what you taste. So classic example is when you smell food, oh, smells like barbecue, grilled foods. And when you taste it, it does taste grilled. Okay. Then you have to remember that when you are testing for anosmia and it is bilateral, you also have to test for taste. And the elementary taste sensations, basic would be your four groups. We have sweet, we have sour, we have bitter, and we have salty. So we will be taking up in another module the sense of taste. So how do you test for anosmia or the loss of smell? So always remember, we need to use non-irritating olfactory stimuli. What is recommended is vanilla, peanut butter, cocoa, tobacco, coffee, okay? You can also use chocolate, okay, or something sweet. Now, in the Philippines, a lot of medical students use menthol, but you have to be careful because the menthol should be something mild, menthol or peppermint. Do not use something which is noxious. Now, question, if I use a noxious stimuli, what cranial nerve might be stimulated aside from cranial nerve number 1? So what cranial nerve may be stimulated aside from cranial nerve number 1? Okay, it's actually going to be the trigeminal nerve. Okay, so you're going to stimulate irritating substances, noxious substances will also trigger or stimulate cranial nerve number 5 or the trigeminal. So this is what I want everyone to remember, what to avoid during testing. What is highlighted in the book is ammonia. Do not use ammonia or similar pungent or noxious substances. I would like to remind you as medical students as well as doctors and paramedical individuals, avoid use of alcohol. So you are actually not going to test the sense of smell because the primary irritating effect will actually stimulate, okay, the mucosal free nerve endings of the trigeminal nerve. So cranial nerve number 5 is stimulated. Now we also have the scratch and the sniff test, okay? And this was developed by the University of Pennsylvania. So this is how the smell test looks like. You're gonna scratch, then you're gonna smell it. There's actually 40 odors which are being tested for, and this is compared by standardized olfactory performance matched with people of a specific age and sex. Okay. Now, other tests mentioned in the book, we have the olfactory evoked potentials. This is available in some centers in Manila. Okay. Then we have the air dilution olfactory detection tests. Okay, these are very fancy tests, which I actually don't want you to memorize this anymore. Now here, we can actually divide into 3 the categories of loss of smell. It can either be nasal, olfactory or neuroepithelial, or lastly, central. So again, what are the 3 categories of loss of smell? We have nasal, olfactory or neuroepithelial, then we have the central. Now, under the nasal, this refers or includes the odorants which do not reach the olfactory receptors. Then we have under the olfactory and neuroepithelial, the loss of smell here is caused by destruction of the receptors or destruction of the axon filaments of these receptors. Then under central, this would be caused by olfactory pathway lesions, okay? Olfactory pathway lesions. Now, the second category of loss of smell is based on pathology. Now, according to Hendricks, it can either be because of a viral infection, nasal or paranasal disease, or it can be caused by head trauma or injury. Now, under the viral infection, these are the infections that affect the respiratory tract, the upper respiratory tract. It is very important to remember that this comprises the largest group, which can cause loss of smell. I think you have probably experienced when you have a cold or when you have the flu or flu-like symptoms, you can lose the sense of smell. And at times you can also lose the sense of taste as well, or you're going to develop a juicia. Now, question, what is the most frequent cause? What is the most frequent cause of bilateral hyposmia, okay, or anosmia? Okay, the most frequent cause of bilateral hyposmia or anosmia. So the answer is hypertrophy and hyperemia of the nasal mucosa. Okay, the most frequent cause of bilateral hyposmia or anosmia. Hypertrophy, okay, and hyperemia. Hypertrophy and hyperemia of the nasal mucosa. And the most frequent cause of hyposmia, I want everyone to memorize this, is heavy smoking. So I want you guys to remember this because this will come out in exams. Okay, this will come out in exams. So please take note of this. Okay. Most frequent cause of bilateral hyposmia or anosmia is hypertrophy and hyperemia of the nasal mucosa, and heavy smoking is the most frequent cause of hyposmia. Now, these are the other causes of anosmia, which are briefly mentioned in the textbook. So we have chronic atrophic rhinitis. There's sinusitis of allergic origin. We have vasomotor infective types of rhinitis. We have nasal polyposis. Then we have the overuse of topical vasoconstrictors. Now, there is a condition called rhinitis medicamentosa. This is when you overuse your nasal sprays. So instead of treating the condition, you're going to get the reverse, which is hyperemia and congestion of the nasal cavity. So instead of treating nasal congestion, it's going to make things worse. This is chronic use of your nasal sprays. So that condition is known as rhinitis medicamentosa. So please take note of that. So I hope everyone got this. Now, question, what viral infections can cause anosmia or hyposmia? Okay, let's see your answers. What viral infections can cause anosmia or hyposmia? Okay, let's see your answers. Okay, very good. I was expecting COVID-19 would be the first thing you'd probably answer. Now, you know something, COVID-19 is not yet mentioned in your textbook, okay? So these are what are mentioned in the textbook. So we have influenza, herpes simplex, and hepatitis virus. But you are correct that COVID-19 does cause anosmia and hyposmia. In fact, I had COVID-19 a month ago after a trip from the US. When I came back 2 days after, I developed a runny nose. I had zero taste, I had zero smell, and it took about 2 weeks for everything to luckily go back to normal. So influenza, herpes simplex, hepatitis. So what is the mechanism why these viral infections can cause anosmia or hyposmia? So it's basically because of destruction of the receptor cells. And it's basically involving the basal cells. So if the basal cells are severely damaged or destroyed, then this anosmia or hyposmia now becomes permanent. Okay. So yes, you are correct. SARS-CoV or COVID-19 infection can cause anosmia. I'd like to share this with you, okay, that SARS-CoV enters the nose. You have to remember there are angiotensin converting enzyme 2 or ACE2 receptors, which are found in the nasal epithelial cells. So what happens is the SARS-CoV enters the nose. The SARS-CoV will now bind to the ACE2 receptors on the nasal epithelial cells. So here are the ACE2 receptors. This is the nasal epithelium. So there's release of inflammatory cytokines. So there's going to be inflammation. This leads to the destruction of the olfactory epithelium, and clinically, there's going to be anosmia or hyposmia. So this is the basic mechanism for COVID-19. Now, I'd like to share this article by Lee and colleagues, the self-reported anosmia and dysgeusia as a key for symptoms of coronavirus. Now, basically, COVID-19 symptoms, flu-like symptoms, are indistinguishable from other viral infections. It was the presence of anosmia and dysgeusia which was highly suggestive of COVID-19. Now, the catch here is that with the new variants that have arrived, okay, and the subvariants, okay, I want you to remember that there are now people with COVID-19 who do not report anosmia or dysgeusia. But if you do have the presence of anosmia and dysgeusia, then COVID-19 is more likely. Now, another condition mentioned in the book is esthesioneuroblastoma. Esthesioneuroblastoma is a rare brain tumor that originates in the olfactory epithelium. So here is a coronal cut showing you the tumor. I'm going to put an X here. So here, schwach na schwach, it originates from the olfactory epithelium. This can cause anosmia. Okay, this can cause also hyposmia. That's esthesioneuroblastoma. Now, can anyone tell me what this syndrome is? It presents with the triad of anosmia, optic atrophy, and papilledema. What is this triad of anosmia, optic atrophy, and papilledema? This is, okay, this is the triad of Foster-Kennedy syndrome. Okay, very good. And this is Foster-Kennedy syndrome. Please memorize this by heart. So Foster-Kennedy syndrome is usually seen in patients who have a meningioma, a benign brain tumor, which is found on the frontal groove. Because of the location in the frontal groove, okay, this brain tumor would basically compress the olfactory tract. Okay, so this is Foster-Kennedy syndrome. So here, this is the papilledema. This is the optic atrophy. And here is the presence of the frontal groove meningioma. So this is Foster-Kennedy syndrome. Now, anosmia can also follow head injury, and this is usually because of tearing of the filaments of the receptor cells, which are found in the cribriform plate. So I mentioned a fracture of the cribriform plate, okay, can cause anosmia, and usually there's an accompanying ageusia. Now, the reason why there is loss of taste is because when there is a bilateral lesion, which is near the operculum of the frontal lobe or the paralimbic region, okay, the olfactory as well as gustatory receptor zones are very close to each other. They are in close proximity. That is why a bilateral lesion, which affects the paralimbic region or the frontal operculum, would present with both loss of smell as well as taste. Okay, now, what do we call this syndrome? Okay, the congenital anosmia associated with hypogonadotropic hypogonadism. So the mechanism of anosmia here is the congenital absence of the primary receptor neurons. It's either congenitally absent or there's the presence of hypoplastic or lack of cilia. So your keyword here is anosmia plus hypogonadism. This is the famous Kalman syndrome. Okay, this is the famous Kalman syndrome. So this is Kalman syndrome. I'd like to share this with you. Okay, this is a 21-year-old male I saw a couple of years ago, presented with gynecomastia. So take note, this is a male. Okay, 21. There's absence of axillary hairs. There's absence of facial hairs. And this is the size of his scrotum penis. Okay, so there's a micro penis. There's small testicles. So there's hypogonadism. This patient also presented with anosmia. Okay, we did an MRI. There was no brain tumor affecting the temporal or frontal lobes. So this was a diagnosis of Kalman syndrome. Now, there's also a number of nutritional as well as metabolic diseases which are mentioned in the textbook, which can cause loss of smell. And this is a result of sensory neural dysfunction caused by these metabolic diseases. So we have here chronic renal failure, cirrhosis, thiamine deficiency, okay, vitamin A deficiency, and adrenal and thyroid insufficiency. So renal, liver, adrenal, and thyroid, they are notorious for causing anosmia, okay? Now, in what population would you encounter Wernicke's disease? These are usually seen in alcoholics, okay? Alcoholics. Now, there's also toxic agents which can affect the olfactory epithelium. This includes organic solvents, commonly benzene, metals, dust, cocaine. Okay, very important. Cocaine, which basically affects the reuptake of norepinephrine. It causes vasoconstriction of the blood vessels in the nose. There's going to be hyperemia and direct damage to the cilia and the hair cells. Corticosteroids, methotrexate. Okay, the chemo drug methotrexate can cause damage to the olfactory epithelium. Aminoglycosides, okay. However, aminoglycosides are more associated with ototoxicity, okay. Tetracyclines, opiates, and levodopa, which is given for patients with Parkinson's disease. So please take note of this. So take a quick look at these toxic agents. So I'll give you a quick minute to go over this. So these are the toxic agents which would damage the epithelium. Now, there's also a report in our textbook about early neuronal degeneration, which occurs in the area of the hippocampus. Okay, so the hippocampus is part of the temporal lobe. It's in very close proximity. It's in very close proximity to the primary olfactory cortex. The hippocampus is also where memories are formed. So these are the diseases which demonstrate early neurodegeneration in this area. Alzheimer's, Parkinson's, Huntington's disease, Pick's disease, and Parkinson's dementia syndrome of Guam. I want special emphasis and focus on the first two. Okay, so please take note for this. Now we have table 12.1, which I want to give you as an assignment to go over as the main causes of anosmia, whether it's nasal, olfactory epithelium, central, and of course, it might be a case of hysteria, malingering, or psychiatric. So please go over this. Then we have dysosmia or parosmia, which is a distortion or perversion of odor perception where the odor is present. Okay, you smell something that's there, but you smell something else. Okay, so this is dysosmia. Now, parosmia can occur when there are local nasopharyngeal conditions such as empyema or pus, which is found in the nasal sinuses, as well as when there is URTIs or upper respiratory tract infection. Now, some terminologies which you have to know: cacosmia and cacojuscia. So when we say cacosmia, every article of food has an extremely unpleasant odor. So this cacosmia means everything you smell just smells bad. I had one patient, which, oh boy, this was one of the most difficult patients I had, because everything he smelled, he would report it smells like the canal. It smells like the sewer, okay? You can just imagine life with everything you smell smelling like the sewer. He later developed depression, okay? This was a vehicular accident, and I presume this was traumatic brain injury, which led to the perverted smell. Then we have cacojuscia, where the sensations, okay, of disagreeable taste are often associated. So it's going to be unpleasant odor as well as unpleasant taste, okay? So osmia means smell, osmia, osmo, juscia means tongue or taste. Now, let me quickly mention olfactory hallucinations. This can be seen in temporal lobe seizures, or what we call uncinate fits. So when they're having a seizure, what they're going to report is olfactory hallucinations. They smell something, smell of burning rubber, the smell of perfume, but it's actually not there. So this is usually accompanied by alteration of consciousness. Before they lost consciousness, before they had syncope, before they fell down, they smelled something different which wasn't there. This can also be a manifestation of epilepsy, particularly temporal lobe epilepsy. Then we have the term for the higher order, the olfactory agnosia. Okay, so I want everyone to remember that this is usually seen in the alcoholic form of Korsakoff's psychosis. Okay, so Korsakoff psychosis, chronic alcoholics with thiamine or B1 deficiency. So I want you to remember that by heart. So this basically ends the discussion and the summary of smell sensation.